In today's video, we will understand how to position, tilt and rotate the probe correctly to get perfect view step by step. Hi everyone, welcome to MedEase where we make paramedical concepts simple. Echocardiography probe positioning simplified for beginners. Topics we are going to see: basic rules for probe orientation, standard echo views, how to transition the probe one view to another view. Before that, we need to know about patient positioning, which is important to get a perfect echo view. Important of patient position. The heart lies slightly tilted and leftward inside the chest. By positioning the patient in left lateral decubitus, that means left side down, the heart moves closer to the chest wall, especially the apex. This gives much clearer parasternal and apical view. If the patient lies flat, lungs and ribs may block ultrasound, reducing image quality. Standard patient positions for major echo views. First one, parasternal long or short axis view. First, put the patient in left lateral decubitus position, which is angled 30 to 45 degrees. It brings LV close to probe, reduce lung interference. Next, apical 4, 2 or 3 chamber view, same position, that means left lateral decubitus position, but more rotated, slightly more rotated. It improves apex contact and visualization. Next is subcostal view, patient lies in supine position with knees bent. It moves liver up, provides acoustic window under ribs. Last but not least, suprasternal view. In this, patient lies supine with neck extended. It opens aortic arch window. Why it is patient positioning is most important. If patient is not in correct position, it may cause shadowing or dropout in image, foreshortening of LV, misinterpretation of valve motion, poor Doppler alignment which gives inaccurate velocity or gradient measurements. Probe tips to know. Ask the patient to exhale gently. This brings the heart closer to the chest wall. Adjust table height and transducer angle for comfort and stability. In obese or COPD patients, small position tweaks like more rotation or sitting slightly up can drastically improve image quality. I hope you understand the most important thing of patient position. Okay, next we move on to probe positioning. Basic rules for probe orientation. Probe marker. You can see that on the probe like line or dot on the probe. It tells you which side of the image is left. Standard convention on echo mission, left side of the screen is directly proportional to probe marker's direction. If probe marker is towards left direction, that direction is left side of the screen. Moving from one view to another view usually involves rotating the probe clockwise or anti-clockwise, or tilting up and down or sliding up and down. See this to understand. This is sliding, moving the probe up and down, right or left without takeoffing the probe. This is tilting. Just tilt the probe tail without moving the footprint of the probe. And this is rotating the probe clockwise or anti-clockwise. This is the index marker of the probe. Can you see the line? And this is a footprint of the probe. Now we are going to see the probe position for each views. Standard transthoracic echo views. First one is parasternal long axis view. Place the probe on the left parasternal area, third or fourth intercostal space. The probe marker should point towards the right shoulder of the patient, that's around 10 o'clock position. In that you will see the left ventricle, left atrium, aortic valve and part of the right ventrium, which is RVOT. You need to adjust the probe by tilting slightly up or down to bring the LV in center, which is the perfect view of plaques. This is plaques view. See the probe which is placed on left parasternal, third or fourth intercostal space. Probe marker directed towards right shoulder, which is around 10 o'clock position. From plaques, without moving your hand, rotate the probe 90 degree clockwise. The marker points towards the left shoulder of the patient, which gives around 1 o'clock in clock view. You will get aortic level view. In that you can see aortic valve in center, LARARVOT, main pulmonary artery and pulmonary artery branches. Tilting slightly down the probe will bring mitral valve level, which looks like opening and closing of fish mouth. Tilting more down gives papillary muscle level view. In that you can see LV in circular with papillary muscles. This is parasternal short axis aortic level view. See the probe position and marker direction. Next one is apical 4-chamber view. Place the probe on apex, 5th intercostal surface at mid-clavicular line where you can feel the apical pulse, and probe marker must be towards left side, which is around 3 o'clock position. In that you can see 4 chambers RA, RV, LA, LV and interventricular septum. Simple tricks to get a perfect A4C view. Ask patient to exhale and hold. By doing this, apex will get closer and it reduces LV foreshortening. Until the probe anterior or posterior to bring atrioventricular valve in center. Next is apical 2-chamber and apical 3-chamber view. For A to C, from A4C rotate the probe 60 degree counterclockwise, marker towards patient head, which is around 12 o'clock position. In that you can see LA and LV. For A3C, from A to C, rotate the probe another 60 degree counterclockwise, marker towards 10 or 11 o'clock position. In that you can see LA, LV, LVOT, aortic valve and part of RV. See this image. This is apical 4-chamber view. Probe placed on 5th intercostal space and marker towards left sided, which is around 3 o'clock position. Next one is subcostal 4-chamber view. Place the probe just under xiphoid process, which is the lowest part of the sternum. Probe marker towards left side, which is around 3 o'clock position. In that you can see all 4 chambers similar to A4C but from below. Then to get the IVC view, rotate the probe 90 degree counterclockwise. So the marker now points towards the patient's head, which is around 12 o'clock position. What you should see in this is a long tubular structure IVC running into the RA. The hepatic veins may join the IVC just before the RA. The IVC should collapse in inspiration. You can measure this for IVC collapsibility index to estimate RA pressure. This is subcostal view. See the probe position, and to differentiate the view, see the marker direction. Last one is suprasternal view. I hope you remember the patient position for this. Now we move on to probe position. Place the probe on suprasternal notch, which is the upper end of the sternum, marker towards left ear. You can see aortic arch and great vessel in this. See the position. Patient lies in supine with neck extended. Probe placed on suprasternal notch and marker directed towards left ear. This is the aortic arch view. In this video, I just explained about the probe position of major echo views. Apart from this, there are some other echo views. Here I will tell you about one another view as a bonus tip. Once you are in the correct echo view, just a small tilt of the probe can open up new structures. For example, in the parasternal long axis view, tilting slightly upward the probe towards the right shoulder brings the RVOT and pulmonary valve into view. This is the final recap how to transaction the probe one view to another view. That's it. You just learned how to move the probe to get all main echo views. Next topic is about echo view. Don't miss it out. If this helped, hit like, share with your echo classmates and subscribe to MedEase for more simplified paramedical concepts. Thank you for watching.